Well, good morning, everyone. My name is Jane O'Hara. I am a professor and director of research here at this institute, and I will be your chair today for this session, which we are calling Improving Maternity Care, the Importance of Exploring the System and Co-Designing Solutions. So why have we chosen this topic? Well, as you're probably aware, maternity care is under the spotlight like never before. Over the past decade, we have seen a number of high-profile public and confidential inquiries which have illuminated a range of problems within maternity services. And this scrutiny has been undertaken against a backdrop of persistent inequalities in maternal and newborn outcomes, as well as reducing public confidence. We're also witnessing an increasingly demoralised and shrinking workforce and an ever-expanding list of recommendations to implement. Arguably, therefore, improvement in the quality and safety of maternity care has never been more urgently needed. So in this session, we will first hear about a programme of work underway at this institute to explore how maternity services can be improved through working collaboratively with healthcare staff, with families, and those managing services to both characterise the problems and develop solutions. It will also explore what policy and professional bodies are doing to enable services to better manage the risks of maternity care. So up first, we're going to hear from two of my colleagues at this institute talking about their work in improving maternity safety. We will then go on to our panel discussion, and I will welcome and introduce my panel colleagues at that point. You will get a chance to have your questions put to our panel, so get your thinking caps on. And as before, you don't need to wait until the end of the presentations to post your questions. Just pop them into the Q&A function as you listen to the talks or as we go through the panel discussion. So it's now my pleasure to hand over to this session's first speaker, who is Matthew Woodward, who will then be followed by my colleague, Jan van der Scheer.
Hello, I'm Matt, Research Associate at this institute. I'm going to talk about research into electronic fetal monitoring that we did here as a way to illustrate how we can think about work systems. This is part of a three-step cycle where early on we want to characterise and understand problems before we try and develop or implement solutions. I'm going to talk about three things. First of all, introduce you to the idea of a work system. Secondly, to point to a couple of models and methods we can use to help understand them. And I will do that through illustrating examples from this electronic fetal monitoring project. So when you look at this image, I wonder what your eye is drawn to. Perhaps it's the very human-to-human interaction of the midwife looking after this woman who is pregnant. Perhaps you're noticing there's a third person in the room and wondering what their role might be in this space. Of course, there is also technology here, and over on the left we have a cardiotocography machine, CTG machine, and that will be recording the fetal heart rate, the maternal heart rate, and the rate of contractions. And you can see it's got a real physical presence here, with all of these cables coming along to the sensors which are measuring those rates. We'll also be making beeping noises and printing out this trace you can see coming through. It's also very much part of the decision-making process. It's mediating that space between the clinician and the woman. Some of these machines will make a recommendation if a trace is normal or otherwise. And then if you look more broadly again, you can see this is happening within a physical environment. There's a room which has various noises going on. There may be interruptions through the door. There will be heat and light levels, all of which influence this work. And then that, in turn, is within a maternity unit. And a maternity unit will have its norms of practice, informal and formal operating procedures and policies. And all of those also influence how this work is done, even if they are invisible. So how do we make sense of all of this? Well, we used ethnographic type methods, interviews, and many hours of observations at three different units. And we took two perspectives, one from social science and one from human factors and ergonomics. And that enabled us to look at the same problem from different angles. And in this study, we were trying to really understand the problem. And to help us do that, we used a framework or a model called SEIPS, Systems Engineering Initiative for Patient Safety. And this follows Donna Bedian's concept of a structure, process, and outcome. And what I will do today in the short time we've got is to focus on the left-hand side of this model, the work system, which describes these 5 interacting components. And that is a way in for us, if you like. It's a way to make sure that we consider all of these aspects when we study a clinical problem. So to illustrate with a couple of examples, we found there was clarity, or perhaps lack of clarity, about the criteria used to assess the trace. So the midwife needs to look at the fetal heart rate and decide if that's normal, suspicious, pathological. We know that there is a lot of inconsistency between clinicians in doing this task. It's a difficult task. There's a lot of noise in that trace. But also each individual clinician brought their own experience and norms of how they would approach the problem. And then on top of that, the organisation brought in its own set of criteria. So there's at least 3 types of criteria that are used in the UK, and they all use slightly different measures for making this classification. As a way to manage this, we saw that staff used an aesthetic language. They would use terms such as beautiful, raw, dodgy, all rightish as a way to communicate about the trace. And this kind of reflected that ambiguity and uncertainty that came in this area. Also, we saw that there was a danger that the trace became a real focus, whereas in fact any obstetrician or midwife would tell you it's about many other factors that indicate how well the fetus is doing, such as is there pyrexia or bleeding. Another example is human-machine interaction. So there was both issues around the availability of equipment. For example, sometimes leads would be missing and machines would not be charged up. And also discussions around the role of centralized monitoring. So one of the units had a system whereby they could monitor all of the women's fetal heart rate traces from a centralized location, and there were advantages and disadvantages of that. We also saw that some of these machines were deemed as too clever by the clinicians. For example, if a maternal heart rate and a fetal heart rate were quite close, the machine could switch them around, but with no feedback to the user that had happened, and issues with actually getting a solid trace in the first place. And all of this made this a very much less than straightforward clinical task. Then there was social and organizational factors such as high workload that we've heard about in many areas of maternity, different modalities of training being more or less effective, very different approaches across maternity units about how the fetal heart rate classification was documented, and different workflows for escalation. There are also other models that we can use and other techniques to look at issues that might be beyond the maternity unit. For example, the role of clinical bodies or regulatory bodies. So this is called the axiomat method, which talks about the idea of levels and how each level influences the one above or below it. So in conclusion, I've talked about the idea of a work system, these 5 different components that interact. And this can be used to study any clinical system. We used it here for electronic fetal monitoring, using our qualitative methods and different perspectives. This has helped us illustrate that this is actually quite a complex system, anything but a straightforward task. And that's because of both issues around technology, the interaction with clinical knowledge, different criteria, and a raft of organizational factors. I hope this has been helpful, and thanks for listening.
Absolute pleasure to join you here today at this space. My name is Jan van der Scheer, and I'll take you in the next 10 minutes or so in a short journey with a few examples around the co-design of possible solutions. And this is a stage that can follow on some of the things that Matt has already outlined around the importance and an example of how to characterize and understand the problem. And I don't mean to go into all the details of definitions such as co-design or its overarching brother, you could say, co-production. There's some excellent resources out there. But what I would like to highlight is that how we try to apply this in a pragmatic way. We follow the principles that sit behind a range of these co-design definitions, and they focus on nurturing collective creativity and working in partnership. This partnership is about developers and users, or more specifically, it's about healthcare professionals, patients, and all sorts of other specialists that might have a particular view or certain expertise, lived or otherwise, to help co-design solutions. And improvement is absolutely critical for maternity care. We probably have heard already a few things around that today. We might hear even more during the discussion. But it's not like there hasn't been a lack of attempts for improvement. Large scale, and one could say more top-down type of improvement programs have been conducted over the last decades, but they haven't yet led to the kind of solutions and improvements that we were hoping for and that those programs were aiming for. And similarly, if you have something that you could call a solo bottom-up improvement effort, you see that there are maybe a lot of good solutions in terms of local ownership, but perhaps less so when thinking about coming up with the most optimal solutions that don't replicate that's something that's happening elsewhere. And that has a good risk of leading to waste and maybe not the best way of going forward with things. So here's an alternative, and I'll try to give a few examples of what this means, co-designing at scale and doing it inclusively. The first example will focus on something we could call a clinical process improvement. And to make that a bit more tangible, so think about the pandemic. So let's say March, April 2020, and a lot of clinical processes suddenly need to be changed. And these were standardized clinical processes, such as responding to an obstetric emergency, such as postpartum hemorrhage or heavy bleeding after birth. And this suddenly needed to be adapted because what if you need to go in as a clinician for an obstetric emergency, but the person, the service user at that moment is COVID positive? And this is where we focused together with an online collaboration platform, Discovery, that you may have already heard about or will hear about today. And we worked with a large group of people with diverse backgrounds who were at different places. So here we were not just working with maternity professionals, but also infection prevention specialists and human factors engineers to come up with recommendations for good practice when you need to adapt normal practice or usual practice to COVID practice, if you will. So we invited them on the Discovery platform, but we didn't just ask them for their views on, and there's a long line of recommendations. We tried to help come up with the best possible solutions by providing a prompt, in this case, a video, a straw man, if you will, and then providing recommendations about how to improve the practice illustrated in this first draft of the video. Then we invited people to come back again in the short exercise, and then asked to rate recommendations, because in the meantime, we had synthesized over 1,000 recommendations that about 100 participants had provided. And a top 22 was then presented back to participants and asked to rate them. A number of them already reached consensus across the participants, but we invited people to come back again because a number of them, it wasn't quite clear if they should be taken forward or not. In this case, we presented people with the views of the different types of professional groups that had taken part in this exercise to inform a revisiting of the score. And that led that in total a number of 16 recommendations were endorsed for implementation. They reached consensus. They were reflected in an updated video. This video I think has been seen over 130,000 times now on YouTube. It was widely endorsed by a number of key organizations and taken up across the maternity field and widely disseminated and appreciated. And what we try to do as well is make sure that this is not something that becomes a one-off exercise that was only applicable here, but also something that has a deeper and underpinning methodology behind it. And here are sort of the steps that I've actually talked you through, moving from understanding a problem, in this case around obstetric emergency and the adaptations needed for it, this first version of a solution that was sort of the draft video, you could say, working with a larger and diverse group of people, building that consensus and producing learning and sharing this learning and this solution. And to us, they showed that it's possible to build such improved processes, and also doing it at speed, because the actual exercise took about 6 weeks on discovery, and this involved people, over 100 people who at the time were extremely busy, of course, with a whole range of things, and they were able to still provide their extremely valuable expertise at a time of great need. So this is also reflected in the methodology for those who want to dig a bit deeper into how this could be used and applied also beyond maternity care. So I'll then go to another example, a second example, around co-designing major changes in clinical practice. I'll focus in on a few examples relating to something that could be described as detection and response to fetal deterioration during labor. And this is about monitoring the fetal well-being or the well-being of a baby during labor, and spotting if there's anything that might not align with the most optimal conditions that we would like to see, which may or may not then need further intervention. And this is not always happening in the most optimal of ways in all of the maternity units across the UK. And when it does not, it of course has a huge impact on families with potential brain injury. It also has a huge impact on NHS finances with litigation claims, and of course also enormous difficult consequences for staff who might be part of an experience that involves potentially avoidable brain injury. This is where the ABC program, the Avoiding Brain Injury in Childbirth program, comes in, which is a collaboration between 2 of the Royal Colleges and this institute, and commissioned by the Department of Health and Social Care. And much of the tools and some examples I will show in a moment are co-designed with maternity service users and healthcare professionals. And the focus on this area that I'll present it, as well as another area that I won't go into today around avoiding brain injury. I think more importantly, like, how can we start addressing this? So again, we looked at discovery. We wanted to connect and we wanted to think about co-designing at scale. So we first invited a broad range of maternity staff through a survey and asked them to what extent they support a particular kind of approach. In clinical terms, you could say, not only looking at fetal heart rate features, but also a range of other clinical risk factors, a more holistic view, if you will. But also we asked, is there a support for more national standardization? Because at the moment there's a lot of local variation. And again, there was a lot of support for that. What the survey did highlight is there's really a great need for improving the clarity of these clinical definitions and what then constitute a moment when we would need to start moving towards responding and undertaking action if something looks of concern. So we followed up with another survey. And now we ask for views on, hey, what does it then look like? What do you think it should look like when thinking about defining of risk factors and the thresholds that trigger action? I'll take you to one more area that was also part of this wider program, and this is a tool to help detect potential deterioration during labor of a baby. And here you see already a more final product, but it went through a whole range of iterations. Underpinned by human factors engineering principles, we, for example, undertook following initial co-design workshops with a smaller group of people. We had a range of usability evaluations where we used something called a think aloud technique for clinicians to work through an early prototype of the tool and help us inform and make improvements. Then an updated prototype was used in simulation testing in different NHS sites to identify if it's indeed working as well as we were expecting it to be. And also here, based on that, we iteratively improved this ABC intrapartum tool, as it's now called. And last to say, we didn't just talk and work with healthcare professionals, for women and their birth partners. They engage in a range of surveys, interviews, workshops, including a vignette survey and in-depth interviews, where people were asked to view an animation that showed a particular way of providing care and how that could be improved. And based on that, we not only made adaptations to that ABC intrapartum tool that I showed, helping to encourage listening to the woman during labor, and if that woman in labor or the person in labor is expressing concerns, but also a range of communication principles that now broadly inform a whole range of resources, from tools, clinical practice tools, through to training, and of course with the bigger aim of changes in clinical practice. But this is also reflected in some of the work that we have published so far. It's gone into NICE guidelines, so these are leading national guidelines. They follow the same principles around this more holistic approach to detecting and responding to fetal deterioration. And last, to wrap things up around this example, a next stage of work is currently underway around pilot testing of the implementation of these tools, the training, and the view towards helping ensure and support the required changes in clinical practice. And this pilot is informed by a broader scale consultation that we undertook through the Discovery platform with a whole range of different stakeholders and people who have relevant expertise to inform the best possible solutions around how to implement and ensure the most optimal national delivery of this program of work. So to wrap things up, it's possible to do this in a to build these improved processes in a collaborative way with this diverse and distributed expertise. And this is perhaps my wrap up, including some helpful resources that might help guide some of the thinking around this area. Thank you very much.
Well, thank you to our speakers, Matthew Woodward and Jan van der Scheer, for their really fascinating contributions there. I think Matt's presentation really helped us to understand the complexity of, the clinical process, which may seem deceptively simple, is actually an incredibly complex task. And Jan really helped to underline, what the importance of co-design, but also that it can be done at speed and in different ways within maternity services. So now I'm going to introduce my colleagues on the panel. First up, we have Ranee Thakar, who is president of the Royal College of Obstetricians and Gynaecologists. We also have Tony Kelly, who's National Specialty Advisor for the National Maternity and Neonatal Programme at NHS England. And last but not least, we have Nicole Lowell, who is the founder of a charity called B3, Bumps, Birth and Belonging. And perhaps in a moment, Nicole will be able to tell us a little bit about that charity and the work that you do there. So how are we going to do this? I'm going to put some initial questions to the panel, but please do get your thinking caps on, as I say, put some questions into the channel, into the Q&A channel. We already have some there, and I will come to those in a moment. But first to you, Nicole. A key issue in maternity at the moment is what we've described as the persistent inequalities in maternal and newborn outcomes. This is an ongoing problem that we're seeing. Based on what you've heard today, how might we work better with minoritized groups to understand these complex problems in maternity care, but also work with them to develop solutions to those problems?
Yeah, so it's really going back to the presentations actually and talking about co-production. We need to really start by establishing more community-centered, relationship-based approaches with the community. Now, you can say that, what does that mean and how do we actually do it? But it's by recognizing that maternity care issues often extend beyond the clinical setting. So, we're talking about, I see a lot of trauma and isolation that happens within the community. But we're also talking about the different social determinants of health, like housing, mental health, food, cultural needs, and the holistic solutions are actually happening on a local level, with community services. So we also need to be thinking as well about building trust and consistency. I think consistency really is the key here. And bold leadership, to be honest. So that means not just looking at the consultations, but regularly showing up at with community groups, collaborating with community groups, as well as really extending that respect and understanding what we're doing from the ground up, understanding that we are actually creating those safe spaces. And once you come into the safe spaces and come out of the walls of the public sector, you will see that there are a lot of solutions already that are already there. The community are already looking at and building and creating solutions. So we need to be working more together from the implementation all the way through to assessing what, once you come up with the solutions, assessing together what does that has that solution actually worked?
Thanks, Nicole. Some really interesting points there, and particularly around sort of being visibly present within communities and sort of seeking out alternative views and views that perhaps might not be as mainstream as well known. So based on some of that then, Ranee, and the presentations that you've heard, what do you see as the role of the Royal Colleges in sort of supporting characterisation of the problems and also co-design of solutions?
Thank you. Thank you so much. Those were really interesting presentations. For those of you who are not familiar, the Royal College of Obstetricians and Gynaecologists is a membership organization, and our mission is to improve the health of women and girls globally. And maternity safety remains an absolute priority for RCOG. And the only way we can do it is by working with other organizations such as the NHS, other partner organizations, more importantly, women with lived experience. And in addition to that, we also need to influence right from the top with policymakers. So how do we, there are two questions within that one question. One is about characterization of problems, and the other is about co-designing of solutions. So we come to characterization of problems. Obviously, we have members and the Women's Network within the RCOG, and our members provide us with information on what the existing problems are. In addition to that, we work very closely with the Royal College of Midwives when we look after women in labor or post-childbirth, or, we really need to remember that it's not obstetrics and midwifery, we are about maternity. So we need to work together. And we have developed Progress in Partnership initiative between the Royal College of Midwives and ourselves. And Jill Walton, who is the CEO of RCM, and myself visit units, talk to people on the front line. But in addition, with the Royal College of Midwives and the RCOG, we also work closely with neonatologists, sonographers, anesthetists, all who form important part of the maternity system. So that's where we get to know about what the problems are. And we also, in RCOG, in our building in Union Hub, work with various organizations. We have 15 charities there. So we work very well together. So we have a huge network where we get to know of our problem. It's our members, it's women, it's other colleges, other organizations, and also third sector organizations. Co-design is a very, very important question that you ask. I think we have good examples of ABC, which is a close collaboration with TIS, RCM, and RCOG. Again, we do site visits, as I said, and that helps us to co-design. So what is important is that we work with all women, listen to them, and also ensure that all voices are heard. In addition to that, it's important to work with social scientists so that we understand people who know how to implement change and, more importantly, evaluate things. So the RCOG is good at producing things. The NHS England implements them for us, but there is something in between evaluation of these. So that's where the co-production comes in. Thank you.
Thank you. That's a really fulsome answer to my question there. Thank you, Ranee, and some really interesting points. And I'm very glad to hear you say that social scientists are needed, because that keeps us all in jobs in the near future. Tony, I want to come to you next, because Ranee has mentioned, that the Royal Colleges, their role is to sort of, support the development of an understanding and potential solutions, and do that with various different perspectives. What is the role of policy, I guess? Do you consider the policy to be the main lever for maternity improvement? And are there any challenges with that?
Thanks, Jane. And thanks for the invitation. And again, just to echo, I thought the presentation Jan and Matt were very helpful to sort of set the scene for this. I think the easy answer to your question is no. I don't think policy is the only lever here. And I think we've seen a significant shift in the way that NHS England are trying to influence this process over the last few years. And I think that's broadly because we've tried to make a greater emphasis on clinical leadership within the national teams and the way that that feeds down into the system, but also a move away from just using policy for policy's sake as a way of influencing change, and thinking much more around the way in which we use quality improvement methodologies alongside the way policy can influence the way that we work. But I think there are a number of challenges in that space that probably need, we're trying to be very open and transparent about the way we're managing this, but I am fully aware that as NHS England, we also are very conspicuous in adding to that problem as we move along. I think the focus of what we're doing is one of the issues that we need to think about when we're constructing policy. I think, some of the things that Nicole was saying and also that Ranee said already is making sure that we maintain the voice and the view of the women and families who are accessing our services as being the focus of what we're looking at. And also, I think ensuring that what we're asking our clinical teams to engage in from a policy and improvement perspective actually makes sense to them, because sometimes there's a danger that this ends up being very high level driven, very political with both a large and small p, rather than actually being something that feels resonant to those who are working in these services. But again, I think the other key issue is managing the expectations and the ask, because I think a quote from Mary Dixon Woods before has been this sort of innovation thicket that we have to sort of try and manage. And so thinning out and being very clear on the scale of the ask that we're putting onto the system, I think is something that we have to manage better. We don't do it very well at the moment. I think there is a sense of overload out there about the volume of initiatives that we're asking people to undertake. So I think there needs to be a bit of pruning, and equally, we need to make sure that we're prioritizing in the right area. And I think one of the other issues that comes into that is this balance between assurance and improvement. And so we have, the central team, and the new operating model for NHS England is shifting responsibility down to systems. But I think we need to get away from this sort of slightly onerous assurance conversations between system leaders and organizations, and think more around how we can enable improvement to happen. And a lot of that is going to come more with collaboration, which again, we're trying to ensure is enabled through the way that we work with our patient safety collaborative partners, with all of the work that we're doing in this improvement space. But I suppose the other two things I would be a little bit remiss not mentioning would be workforce is a big component of this, both in the fatigue that we are seeing within the workforce, but also the capacity gaps that we do have. And they cannot be underplayed, in the sense that it's very difficult for people to be delivering high quality care and being asked to improve it in the same breath. And the other area, which I think is very central, which we've spent a considerable amount of time and effort over the last couple of years trying to support and address, is the way culture plays out in this space. So you can have the most enabled ideas, but actually without the most enabling culture sitting behind that, we're unlikely to get the kind of grip and traction that we really need. So hopefully that's not too big an answer to your question, but those would be the main I think I need to look at.
Perfect. Thank you so much, Tony. Okay, so I'm going to go to, with all of that in mind, I think we've already had some really interesting points there. I'm going to go to the Q&A, and there's some really interesting questions, but I'm going to just try and tackle a few in one, and go to Jan first to talk a little bit about the Discovery platform, because there's been lots of questions about some of the nuts and bolts of the Discovery and how you've used it as part of co-design. So I'm going to try and bring together a few questions in one. So Jan, how can you talk to us a little bit about how you identified stakeholders to be engaged in your Discovery processes? And also, were patients and families involved in those processes? And if so, had you thought about digital exclusion?
Thanks very much, Jane. So the first bit about identifying stakeholders or inviting participants. So we use a whole range of different methods. We, for example, work closely with organizations, that's the ones that Ranee and Nicole represent. We also work through social media. We work through a whole range of individual contacts that we have, larger professional networks, some more formal, some more informal. In this case, this is an example of if we would be trying to get a broad group of people together that is as representative as possible for the particular population that we're trying to represent, whether it's, for example, maternity professionals, whether it's women and their birth partners, or otherwise. Along with that, just an example, we don't just do and focus on large-scale surveys, etc., through a platform like Discovery. We also work through other means. We have advisory groups that are more purposefully sampled, you could say. So what I mean with that is quite targeted. We look carefully about who do we invite for what, how can we ensure a breadth of organizations and perspective are represented, so that they can then start provide their perspectives on this, perhaps this broader range of views that we have been collecting. And that bridges perhaps a little bit also to the point of digital exclusion. Of course, every method has its limits. I think for example, we often hear, well, maybe older adults wouldn't engage with it. Well, our user research suggests that it's very broad and very a lot of different people who can make use of these kinds of tools, but definitely there are ways to combine the best of both worlds. In our research, much of what wasn't presented today, we've also combined it with going out to community groups and working with organizations such as the ones that Nicole represents, where we really wanted to get closer. And that's not something that we as researchers would be able to do. We then work in collaboration to then find groups to find a setting in which people can talk about the kinds of issues that we want to be addressing and that we want to be learning about. So it doesn't. I think it starts to provide some answers. I hope I haven't meandered too much, and if it is, please do bring me back to what we should be discussing.
Not at all. Thank you, Jan. Okay, so there's been a really interesting question here from Joe Daggerton, who is asking about the focus of the work that we presented here, and rightly said that it's probably focused on more of the upstream intrapartum care work rather than actually looking at the full maternity pathway. And she's saying, in terms of overall effectiveness, are we focused on the right place? If we don't look at some of those earlier upstream factors, we potentially misunderstand the problem, or indeed don't necessarily create appropriate solutions. So first, I'm going to go to Tony, really, for your thoughts on that, if that's okay.
Yeah, no, I mean, I think it's an incredibly important area in question, and something I think we, again, have to keep our eye on when we are trying to plan the way forward, because the temptation is to deal with the easier problem in front of us and duck the bigger problems. I suppose there are two other ways I would sort of probably think about this. One is you can't see, I think one of the areas where we fall down on, apart from translation of effective best practice into day-to-day clinical practice, is we struggle to address how we deal with unwarranted clinical variation within the work that we do. And I think one of the areas where improvement bears real fruit is by stabilizing and standardizing practices. And those can be very much close to where we're looking after and providing care to, in this case, women and families. So actually ensuring that through the work that this and RCOG and RCM are doing in the fetal monitoring space, for instance, we're trying to bring in a number of factors close to the woman from the fetal monitoring point of view, but standardize the way that we do that to try and eliminate some of the variation that leads to, the outcomes we don't want to see. But I think what we can't do is then just make that the panacea for the improvement. So looking at the upstream impacts But some of this is within our gift, say within maternity, to improve. So some of that can be much more effective real-time risk assessment, which can start at the point of booking for that woman. Some of it interplays with other initiatives that we might have. So on reducing the number of women who are smoking during pregnancy and supplying support for that, ensuring we've got better care of women who may develop diabetes. A number of these factors will then play into the intrapartum space. But some of the wider determinants of health, I think, are much harder for us to actually get a handle on and impact. So we know that, deprivation is going to play into this in a big way because of the way women may access care and the way they may come into pregnancy healthier or less healthier. We have a rise in the number of women who are coming into pregnancy with a raised BMI. And actually, some of these factors are very difficult for us to mitigate within maternity. And I think that public health agenda is something that we do need to try and support and influence. But it doesn't, I think sometimes our view, it can be quite blinkered, but that doesn't mean we're not actually sort of cognizant of some of this. But there are some things that are very much within our gift to change. And so I think for me, it's a balance between the two. But I think the point is incredibly well made.
Indeed, and I think so I was going to invite Matt really to come in on this point, and because obviously we've, within this, we've used a particular framing for looking at the problem and characterizing the problem. Those sorts of human factors methods, are they appropriate to look at the wider pathways? I just wondered if you wanted to comment on that.
Yeah, absolutely. Thanks for the question. When you look at a model like SEEP, Systems Engineering Initiative for Patient Safety, it does cover both a microsystem, if you like, so a clinician and a patient and a piece of technology maybe, but also organizational factors. I also mentioned another method there called AxioMaps, which explicitly has levels that talk about the role of regulatory bodies, people like the CQC, and in the example of EFM, I talked about that there's 3 different sets of guidance that are put in place by really kind of national level or European level bodies, and that influences on the day-to-day work. So yes, Jane, there are several models that we can use that try and capture both the micro, the meso there in the middle, and also the macro level policy effect.
Great, thank you. And I would absolutely concur. And there was another question about comparative work on looking at different types of models or frameworks for looking at the system, and they do reveal different things. So there's definitely a case to be made, I think, for using all of the tools in our arsenal, if you like, to look at this problem across the entire pathway. So there's been a really interesting question here about supporting maternity units working within deprived communities. We've got about 4 minutes left now. There's been loads of questions in and we won't get to them all. But I'd like to come to you first, Nicole, if that's possible, because obviously you're working with a particular community in a particular part of the world. Do you feel it's harder for maternity units to working within these communities to implement change, or how might we do this differently?
I don't think it's harder. So so I'm a midwife as well. I'm a midwife by profession, and I've left midwifery to go into this particular sector to make more of a change, because I found it quite difficult to make the changes from within the system, and I think standardization of processes is great, but the thing is with maternity services is that it is bespoke by design, right? And we have to look at each person as an individual. The standardization is great, but we are missing that bespoke element, if that makes sense. And when it comes to actually problem solving and going into these type of communities that I work with in Essex, I really don't think it is that difficult. It is just having those really simple conversations with people, listening to people, validating those experiences, and understanding that the VCS sector, like problem solving and collaboration, is not tokenistic. We're doing a lot of work on the ground, and we are professionals in our own right, and recognizing that we're professionals in our own right, and that we are we are more than willing and able to come up with these solutions with the public sector. Something else I just really wanted to quickly talk about as well was that the outcomes can't be delivered by the public sector. Outcomes are created by whole systems, by healthy systems in which all people collaborate. So it's not on the public sector to create these outcomes. We need to look more. You talked about different factors and different ways of finding solutions, but we need to really be, I feel like we need to be looking at the human learning systems, looking at the more humanistic approaches to this. And when you was talking about midwifery and capacity, or maternity services and capacity, I'm a really strong advocate for midwifery and for midwives and what we can achieve. And I think midwives are really well positioned to make those changes, especially with communities that are from more deprived areas. But it's actually, once again, just putting that respect back in the respect and that understanding back into maternity services. Midwives are absolutely great, and I think we've just gone a bit too far into medical systems and losing that's really humanistic. Let's talk to each other, let's learn from each other factors when we're talking today. So yeah.
Thanks so much, Nicole. I think your point there about this is a whole system problem is particularly it's a great way to finish this session, I think, because picking up on some of the issues that we've talked about before, that actually we can't just focus on intrapartum care, we can't just focus on the early parts of the pathway, we can't just focus on the public sector involvement in that. We also need to look at the wider charitable sector and public health and all of these different kinds of things. So a really great message, I think, to finish there. I'd love to put loads more questions to our panel here, but we've sadly run out of time. So it just remains for me to thank all of my panelists for coming along today, in particular Ranee, who's reorganized some of her work, her actual proper work, doing work in maternity services at the moment. So thank you so much, Ranee, for joining us and braving the NHS Wi-Fi. So up next, we have two parallel lightning talks presented by this Institute Fellows Justin Waring and Lyle Russell. And shortly, you'll have the opportunity to choose which session you'd like to join. Thank you so much to you all for engaging so brilliantly with this session, and I hope you enjoy the rest of the conference.